So inferior vena cava filters have been around for over 40 years now. They were introduced in the late 60s and early 70s. And despite being in use for so many years, there's still significant controversy about when they should be used. So the indications for using an IVC filter can be absolute indications, really documented benefit from the use of the filter. And these indications are very specific. We have a documented DVT, proximal DVT with contraindication to anticoagulation. If you have a recurrent pulmonary embolism despite the patient being on therapeutic anticoagulation, this requires verifying that the patient is compliant, and you need to base the decision on at least 2 consecutive therapeutic INRs. And then a patient who is on therapeutic anticoagulation, but because of bleeding complications, needs to have this anticoagulation regimen discontinued. There are some relative indications, the most significant of which is patients who have a large PE and are relatively unstable, and in whom another PE might really tip their health in a very negative way. So these patients are considered for IVC filter placement despite the fact that they can be on anticoagulation at the same time. And there is some recent evidence that in this particular patient population, placing an IVC filter has really an advantage when it comes to survival. And finally, prophylactic use of IVC filters. This is use of IVC filters in the absence of a documented DVT. And for years it's been debated that patients who are undergoing surgery for pelvic malignancy, or patients who are undergoing surgery for morbid obesity or orthopedic and spine surgery, and trauma patients, particularly those that have multiple trauma, they should have an IVC filter placed despite the fact that they don't have any evidence of a DVT. A lot of these indications have been debated, and in some of them there's good evidence that they should not require an IVC filter placement. What we have witnessed is an exponential increase in the IVC filter use, particularly in the United States. And this is clearly a big difference between the US and Europe. From 1999 to 2008, in the Medicare population, the IVC filter placement rate almost doubled. But what really is impressive is what happened after 2008, particularly if you look at these numbers. In the year 2012, there were 225,000 IVC filters inserted in the US. Now, if you take the big 5 European countries, which population-wise match the US population, there were only about 10,000 filters inserted. There is like a huge difference when it comes to use of IVC filters on the two sides of the Atlantic. Interestingly, there is no difference in venous thromboembolism-related deaths if you look at the data from these countries. So why are we seeing this huge increase in IVC filter placement in the US? Part of the problem is psychological. The introduction of retrievable filters back in 2003 gave the false sense that you can put these filters and you'll take them out later, but the fact of the matter is that very rarely those filters are being retrieved. The option of bedside insertion has allowed placement of these filters in critically ill patients in the ICU. And then in 2002, the East Trauma Guidelines, which I will talk a little bit more in my next slide, came to the US and suggested that patients who have multiple trauma should have a prophylactic IVC filter placed, particularly if the trauma involved spine. Of course, reimbursement is a big motive for performing a quick procedure that was priced at a very high level in the US, because the CPT code used was the same CPT code that was used for open cable interruption. And then a medical legal environment which in the US promotes prophylactic procedures such this. People would not want to have a PE complicate their procedures, and when it came to specific patient categories such as the morbidly obese patients, there was a big push from the physicians who were performing these procedures for their patient to have a prophylactic IVC filter placed. This is the East Trauma Guidelines, and they came out in 2002 and created a big trend between the trauma surgeons in the US to insert those IVC filters. But the fact of the matter is that if you adhere to the EAST guidelines, you would need $380,000 for each quality of adjusted life year saving. And that is clearly not cost effective. In addition to that, a study from Penn State Trauma Service challenged these recommendations and found that if you looked at patients that followed the EAST trauma guidelines and those that did not undergo a filter placement, there was no significant change in the rate of FTE. So in our experience, actually the experience in our own institution, we looked at our data from 2007 to 2009, and we found that in our own place, we had a significantly increased rate of IVC filter placement, and a large number of those were filters that were placed for prophylactic indications. The majority of these prophylactic filters were inserted by the trauma service and were in trauma patients. Our retrieval rate was dismal, was only 8.8%. So why do we really care about placement of IVC filters? Particularly with the new generation of filters, with the retrievable filters, a number of IVC filter complications have been reported. Deployment outside the cava, symptomatic DVT at the site of insertion, filter migration, filter fracture with component embolization, filter erosion of the IVC, IVC thrombosis, and the increased incidence of DVT and post-thrombotic syndrome, and finally cardiac tamponade. You can have a P despite IVC filter placement, and everybody has a false sense that if you place an IVC filter, a P may not happen, but P may happen either from sites that are not drained by the IVC, or by small thrombi that can pass through the filter, or if your filter is placed in an eccentric position and doesn't clearly prophylax the patient. And then development of thrombi above the filter or propagation of thrombi through the filter. This is a classic example of a thrombosed IVC filter, duplex ultrasound, and this is a filter that has captured a significant amount of thrombus and has caused thrombosis of the inferior vena cava. This is a patient that came to our own institution. You can see those fragments of metal in the heart that have gone through the myocardium and they have created pericardial tamponade. And you can see that in a different projection on the CT scan. So this patient had a retrievable inferior vena cava filter placed about 7 years prior to this presentation. And if you count the filter appendages, you can only count 9 of them. There should be 12. So he had 3 different limb fractures with embolization to the heart. This is a filter that was retrieved from the right atrium. And this is a case of a patient that had a prophylactic filter placement. This guy was a trauma patient and came back with chronic abdominal pain. All of the rest of his workup was negative, and you can see that the filter the filter limbs have actually perforated through the wall of the filter and are affecting different side structures, including the wall of the aorta, the duodenum, the right renal vein, and the retroperitoneum. Now, this patient had an open retrieval because we attempted a percutaneous retrieval without success. And this is the picture of the inferior vena cava with the prongs of the filter protruding through it. And this is what we had to do. We had to cut those limbs and then pull the filter from the jugular approach. The FDA has caught up with that, and in 2010, it posted this communication that the number of device adverse events reported to the FDA with retrievable filter had increased. A number of them involved device migration, filter or component embolizations, perforation of the IVC, and filter fractures. And then the magic words came that the FDA is concerned, and the recommendation is that all the filters that are placed and they are intended to have a temporary role should be retrieved, and that should be the responsibility of the inserter physician. We did look at that MOD database, and what we found out is that since the use of retrievable filters became widespread in 2003, you can see an exponential increase in filter-related complications, and a number of these complications were perforations, with a significant component being symptomatic perforations. The organs that were penetrated during perforation are listed here, and you can see that the majority of these involved the small bowel and the aorta. Of course, the lawyers had a party with this. You can see here that they are suggesting and they're offering free case evaluations if you had a filter placed at no cost. So, why are those filters not retrieved? The fact of the matter is that a lot of these patients are lost to follow-up. They're being discharged from the hospital. They are going to rehab centers, or they go on with their lives and they totally forget about the filter. This study showed that depending on who was the initial consulting service and who was the practice that inserted the filters, resulted in a significant difference on the retrieval rate. So if the medical service had requested the filter, and the filters were usually placed by interventional radiologists, the retrieval rate was very low. Whereas when the surgery service was involved, the retrieval rate was slightly higher. And I think that this had to do with continuity of care in these patients. So, in order to prevent complications, the indications for filter placement must be carefully reviewed. If you think that you need a filter for a short period of time, then a retrievable filter should be placed, but also should be followed and retrieved. But if you feel that the filter needs to be permanent, then a permanent IVC filter should be inserted. Those filters are related with a lesser rate of complications. So, in conclusion, filters are indicated for a small percentage of patients who have acute proximal DVT and contraindications for anticoagulation. Whenever you can, retrievable IVC filters should be preferred, and these patients should receive IVC filters unless they have permanent indications to anticoagulation. Anticoagulation should be initiated when appropriate for these patients, when it is considered safe, and the filter should be removed soon thereafter. And most of the evidence suggests that IVC filters should not be used as a primary method of thromboprophylaxis for high-risk surgery and trauma patients. Thank you.